Good morning. Today, like Sir said, we look at the part 2 of appraisal of medical literature on social media. For those who've been here last week, just a quick recap. So last week what we looked at is a framework for interpreting information directly from the platform. So we had looked at one video and we had seen if the domains that we had used were trustworthiness, whether they were credible or not. Accessibility is if it was open access or if it was a closed access. Usability is essentially readability. And privacy and confidentiality, if you need any login details to access the article. So these are the 4 domains that we had used last week to appraise the information that is directly given on the platforms. This week it is essentially a guide to help clinicians appraise and interpret studies that use the data from all these platforms. So why do we need to do this kind of study? Firstly, about 70% of the Indians rely on online data for their health information. There is an increase, now that there has been increase in social media usage, there is also a parallel increase in the number of published studies that use data derived from these social media. If there are no guidelines to tell people as to how to do it, there will be an improper sample selection, improper sample size, improper selection of the platform, giving rise to poorly conducted studies. Hence, you need the framework to help physicians and clinicians appraise and interpret studies that use data from these platforms. So for that, so this is published in the BMJ Evidence-Based Medicine. So we all know Gordon Guide, he's authored the JAMA textbook. So they have come up with these users guides from the medical literature series, how to appraise studies using data from the platform. Okay, so the question is, so like I said last week also, because we are all so familiar with CAS, I tried to replicate CAS as much as possible for ease. So did the study explicitly address a sensible question? So social media platforms are contemporary, ubiquitous, publicly available, and they are very dynamic essentially. So they have the potential to significantly influence healthcare decisions. They can be really correct and they give you accurate information, or they can be really wrong and mislead patients and subsequently patient care. So the first important is to understand the rationale for study design. Why did we decide on choosing the data from the social media as opposed to many other platforms that are available? And if this data from the social media platform is suitable to answer the question that we have at hand. This is the first question. So what are the few rationales for conducting a study of social media outlets? So the first one is evaluation of the content accuracy. So if we were to, so I just want to highlight a few examples for each of these things, just so we are familiar with these words. A lot of these words are new for me, and I thought we should all also look at interpreting these words per se. So for content accuracy, let's say, so there was one study that had looked at SLE on YouTube, and it found out that 90% of the videos on YouTube did not have any misleading information, which means that the doctor can, with fair degree of certainty, can recommend this. Okay, so all these patients with SLE, he can tell them that okay, maybe you can all use this platform to derive your information. So that is one way. Next thing, survey of healthcare consumer values, attitudes and preferences. For example, there is a study that had looked at, so let's say gene therapy is like a new thing, not too many people talk about even amongst our circles. So one man looked at what are the concerns of the patients who want to have gene therapy have. So he had released an online survey sort of thing, and all the patients had put in what is gene therapy, what are ethical dilemmas with gene therapy, is it legally acceptable. So he's put out this thing, and then there are a lot of field-in articles. So that is essentially looking at attitudes and what they would prefer. How can I go about doing a gene therapy sort of thing. So assessment of personal patient experience with disease or treatment. So first-hand patient testimonial. So this is like very close home, like the new thing that we are doing, patient first campaign. So you can always give in a testimonial, or you can always give a complaint. So based on, or rather Google reviews. So based on those reviews, patient will choose whether they want to come to our hospital or not want to come to our hospital, this doctor versus that doctor. So that is one way of getting patient experience. Second thing is determining appropriate public communication strategies. So for example, if you have to discuss about, there are some 5 videos on Ebola virus. So there's an Ebola outbreak, or let's say there's a Nipah outbreak in Kerala. Some 10 videos are talking about it. To assess how accurate they are not, we need study that is assessing them. So that is one way of looking at it. And establishing research agenda. There has been increasing preference to patient priority in research as opposed to what the researcher wants. Patient outcomes is what you think. So there are these. So this is one study that was done on atopic dermatitis. So the doctors wanted one set of outcomes. They felt the ESR has to come down, CRP has to come down. While the patient said, I just don't want to get admitted. To look at the difference between what the patient wants and the doctor wants, you can use these platforms. So these are the different ways in which we can use this kind of study. So was the search, the second question is, was the search comprehensive? So for this, we want the study to be complete and representative sample of the content to avoid misleading results. Like I said, a study which was done on SLE had shown that 90% of the videos did not have any misleading content, which means it is reproducible. Sorry, I don't want to use that word, which means that you can suggest it to patients. Inclusion of more than one platform. When I say social media platform, it's not just YouTube, Facebook, Twitter, whatever it is. So the more platforms that you include, the more likely you're going to get good information. However, a particular topic might exist only on one platform. Let's say we are talking about a complicated orthopedic surgery. So it may be only present on OrthoBullet or something of that sort. So depending on the question we have in mind, we are to choose which platform you want to pick it from. The search requires multiple search terms. When the review focuses on materials for patients, emulate the approach that patients use to search social media. Let's say, for example, we want to see what the patient's perspectives on gallstone diseases. So for that, the wiser way of looking at search keywords will be gallstone disease, gallbladder disease, as opposed to cholelithiasis, cholecystectomy, choledocholithiasis. But if you're looking at a clinician perspective, you use the second words. So depending on what you're trying to assess, your search words also has to change. Next thing, study should also make sensible and accurate conclusions that are supported by the specific research criteria. So for this, there is a study which was done on gene therapy, and it had said that only about 10% of the studies had mentioned about complications. However, the search word had never had the word complication. So if you do not have an appropriate search word, you are likely to make false conclusion, and you are likely to tell the patient that, okay, so do not follow this for this particular diagnosis. Next thing is the platform search filters such as view count, relevance, or date of creation to achieve comprehension. So view count is the more the views, the more likely it is more representative and likely to discriminate. Relevance is the closest to your search term. Date of creation, you are likely to get the newest articles before the older ones. So I just thought like why we need to do. So recently we all looked at exit polls. So depending on what platform you are choosing, your exit poll reports are also very different. This is a clear example of how choosing the right platform becomes. And we all know how different they were from the real results. So the next question is, was the study process reproducible? Studies should address a focused question that are defined a priori. A priori is basically you have made the question before and then you are looking at a search, not the other way. You look at few studies and then you make up a question and you make of it. The question can be defined using the familiar Picot statement, which is patient intervention comparison outcome framework, or you can use another format. This is mostly for the qualitative studies, which is perspective, setting, phenomenon, interest or problem, that's P, environment E, time or timing, and findings format. So I have just given an example. I want all of us to remember this. So we are going to do a small activity at the end of this talk, and we should all come up with a Picot statement or this statement. So from the perspective of a patient, so per is perspective on a Twitter platform. So S is for setting. So S is for setting. Messaging regarding the HPV vaccine, which is the problem or phenomenon of interest in online social media outlets. That's the environment. Over a 2-week time period, which is the time or timing, is perceived as positive, neutral or negative, which is the findings format. So this is for the quantitative studies, and this is the format that they will be using for the qualitative studies. So was the study process reproducible? So because it involves picking, so the investigators are expected to pick the studies, pick the videos. So the investigators are making a judgment regarding the relevance, content and accuracy and how it should be. So there is going to be a lot of bias. So to reduce the likelihood of error, bias and subjectivity, it is best to be performed by 2 or more the merrier, independent investigators. They should also evaluate and report agreement among reviewers. If 2 people do not agree on one thing, what is the degree of disagreement or agreement? How did they handle the disagreements? And if they observe substantial disagreement, provide potential reasons. Why does one person think this way? Why does one person does not think this way? So here again there are 2 ways of dealing with this. One thing is 2 of them sit together and decide to come to a consensus. And the other way of looking at it is both of them give their views and each of them have reason as to why they feel that way. That way you will have a broader understanding of the theme in context. So next question is, were the synthesis methods of the study appropriate? This is essentially our methodology or the outcomes that we use. The first one they can use is narrative analysis. Narrative analysis is basically when you have a similar study being done on different groups of people. Let's say scrub typhus in children, scrub typhus in adults, scrub typhus in pregnancy. By virtue of the study they are all the same, but you cannot mathematically put them all together. So you will just narrate the whole event or the outcomes. Quantitative is the done that we know, sorry there is a typo, and qualitative analysis that we had done about 3 weeks ago. So the other way of looking at it is a Likert scale. Likert scale is basically the you can number them based on 1 to 3 or agree, disagree tool or versus useful, not useful tool. Or pre-validated quality appraisal questions. One of the pre-validated quality appraisal questions is a modified discern score. So one of the studies that had actually looked at pain in spinal cord stimulation had actually divided the studies into good versus bad based on the modified discern score. If the score was more than or equal to 5, it was a good study. If it was less than or equal to 3, it was a bad study. So what were the things in that thing? The first thing is the aim clear, concise and understandable? Are the sources of information reliable? Is the information presented balanced and unbiased? Are additional sources of information listed? Does the video address areas of uncertainty? So these are kind of similar to what we have looked at last week. That was we were appraising the individual video like last week. So these 5 things are actually kind of similar to that. Actually, this was one of the tools that they had used to come up with those 4 domains. So you can use a pre-validated appraisal scales like this, a Likert scale, or a qualitative appraisal or a quantitative appraisal depending on the data that you get for analysis. So what is the certainty in the findings of the study? So this is essentially means how much confidence can you place in the findings of the study. So it is analogous to the grade system, which I will take you through across in the next slide. In the qualitative study, the analogous thing to grade is a grade qual, which is confidence in the evidence from reviews of qualitative research. So let's just look at this. So basically, you have high quality of quality of evidence, which is the highest quality systematic review and meta-analysis. Then RCT, then cohort, then case control, then anecdotal reports and all that. So this is the quality of evidence which is the highest. So if you have very evident, like which you have net benefits or net harms, where it is completely on one sided, then it is a strong recommendation. However, you have some trade-offs, which means like let's say in a RCT, if one of the 5 things that we do, randomization, allocation, concealment, alignment. If one of them is missing, then you downgrade it by one. So there's a little bit of trade-off. At that point in time, you use values, preferences, patient preferences, doctors, and you do that. So this grading is essentially taking into consideration the quality of the level of the evidence and the outcomes that it does, and based on that you are given strong, weak and no recommendation. So expert opinions hold no recommendations at all. So the same, and this is for quantitative analysis or numerical analysis. For qualitative analysis, they have what is called CERQUAL, grade CERQUAL, which is confidence in the evidence from reviews of qualitative research.
Just say one more point on the high picture. When you say high quality moderate, so when you do a critical appraisal, we looked at randomization, allocation, blinding. That is one part of quality. The second part of quality is, okay, now we're doing a review of many studies together. Is the evidence having heterogeneity or inconsistency? That's an extra point which comes in the grading of evidence. What is the precision of the evidence? If you remember, we looked at the summary diamond figure in systematic review. Many studies together, we summary evidence. There's a wide confidence interval which is imprecise. So what is inconsistency? It is heterogeneity. Secondly is precision of the result. Thirdly is the outcome exactly what you want or something like what you want? If it's not exactly what you want, you say the outcome is indirect or less direct. So directness of evidence. And the last one is publication bias. You search all the literature, but they forgot many important databases. But they only got 4 or 5 studies. We think there must have been at least 10 or 15 studies. So if you add everything together, including what we usually do, plus these extra points, then together we come to high, moderate, low. This is for RC. But for cohort studies, you say, okay, the evidence starts at low, but if the cohort is very well done, good assembly of patients, very low loss to follow-up, outcome assessor blind is correctly done, and the odds ratio is very high or relative risk is very high. So I'm just mentioning some rough points, but you can upgrade what starts off at a poorer design cohort, you can upgrade it to a higher quality evidence. So it's not that RCTs you assume is high quality, and for if randomization is not appropriate, you start saying, okay, not good, not good, and then finally if it's inconsistent results, you downgrade the evidence. Or you can upgrade. So grading system will come to that. Finally, the grade will say strong recommendation or weak recommendation. So instead of nowadays putting level A, B, C evidence, in A, B, C you put 1A, 1B, 1C. Now people are saying just strong recommendations, weak recommendations. This is the new grade system. But this is grade, just taking the picture for RCTs. The similar grade system is there for qualitative studies. So a similar thing is going to
The next thing is, what is the certainty in the findings of the study? So one thing is the study limitations. So most of the studies that we take are going to be descriptive in nature, while some of them can have cross-sectional case control cohort or randomized. Usually the studies are mentioned across an appropriate reference standard, preferably a systematic review. So let's say, there is a study which is talking about COVID-19 vaccines. The best thing would be to mention all the RCTs that are talking about a COVID-19 vaccine. Next thing is an adequacy of data. It is essentially similar to imprecision. So the most common thing that they do is when they use the number of views, they pick up all the studies which have the maximum number of views. So it is common to think that larger studies are more valuable than smaller studies, and all the larger studies are picked and the smaller studies are lost in the process. So in the qualitative research, the overall determination of the degree of richness and quantity of the data supporting the findings is what it is used. So because it is quantitative, there is no sample size calculation. But based on the topic in discussion, we can decide on that. Let's say we are talking about secukinumab in psoriasis, let's say. Our sample size is not going to be very high as opposed to talking about just psoriasis in itself. So depending on the question in hand, we have to decide on a rough estimate of sample size. There is one other way that this study had looked at, which I will deal with later. So next thing is the same thing, what is the certainty in the findings? Next thing is inconsistency. So you can have inconsistency of results within one platform, let's say across just Facebook. or you can have it with Facebook, YouTube, Twitter, whatever. So that essentially we look at the difference across each of these studies while we are looking at a meta-analysis. So differences in studies across platforms may be explored in the way that we look at the studies in a meta-analysis. Inconsistency of content within the platform, different studies on the same platform may also be present. It basically, let's say there is a study which was looking at diabetes on the same platform. Some studies have looked at different domains like symptoms, signs, investigations, and treatment options, while some of them have only looked at treatment options. So depending on which group of people you are trying to cater to with this information, you can ask them to book either one of that or either this or that. Next thing is indirectness. So this is like what will the results of your study apply to your local population? That is this is the analogous to that question. So the issue of applicability refers to whether study conclusion can be applied in the care of the desired patient population. One thing is accessibility. Let's say there's a study on statin therapy and you're looking at Twitter. So however in Twitter, most patients, 90% of the Twitter users are less than 45 years of age, but 90% of patients using statins are more than 45 years of age. So for the question in hand, you have actually picked the wrong platform. So for that, maybe you can pick up Facebook, where at least 50% of them are actually more than 45 years of age. For the question, pick the right platform. That is accessibility. Next thing is socio-economic and cultural differences. Most of the non-English videos are lost in this filtration, so it may not clearly represent the Arab population or African population who don't speak English. Next thing is cultural differences. One thing, let's say for example HIV, different things work differently. Let's say circumcision is known to reduce the incidence of HIV, but like in the Arab countries where circumcision is more prevalent, they are likely to accept it, while in African countries they are not likely to accept. So socio-economic and cultural difference make a huge difference. Patient choice of platform. Let's say for example we are looking at hidradenitis suppurativa. The figures are going to be they are not very pleasing to the eyes. The patients accessing it also would want to be accessing it from something which is which is private and not very public. So depending on the question, again you choose what kind of platform you want to draw your data from. So at the end of it, these are the 5 questions. First thing is, did the study explicitly address a sensible question? So if we have to use it like the CASP questionnaire, you can just say, did the study address a specific question? That was the first question. Was the search comprehensive? Were the synthesis methods of the study appropriate? This is essentially the outcome methods. Was the study process reproducible? This is the flow chart. What is the certainty in the findings of the study? How much confidence do you have in the findings of the studies? So in that it would have been confidence intervals or odds ratio and hazard ratio. So this is how you would compare that with this. Okay. So now that we have looked at the guidelines, I will appraise one study. So the clinical scenario is the recent statistics from the National Health Mission have revealed a troubling decline in childhood vaccination, especially thimerosal. So thimerosal is basically the preservative that is used in a lot of vaccines when they have inactivated vaccines. During the latest monthly meeting, an officer reported a noticeable increase in online activity by the anti-vaxxers, suggesting a potential link between this surge and the decline in the immunization rates. In response, the director has called for an investigation to verify the accuracy of this claim. So for that, I have picked this YouTube as a source of information on immunization, a content analysis. So did the study explicitly address a sensible clinical question? So like I did last week, I put some hints here so that we can all use this. So the study expressed concerns about the veracity and the quality of information regarding immunization from internet-based sources. Because YouTube is one of the largest publicly available video sharing sites, they have used YouTube. Ideally, they should have used they could have included other platforms like Facebook, Twitter also. They had a specific research question, which is what information is being conveyed to a patient who watches YouTube videos regarding the risks and benefits of immunization compared with the known reference standard. I think this, to answer this question, this study design is an appropriate method. So the analogy of the picot statement is this. So from the perspective of the researcher on YouTube platform, this is per his perspective on the YouTube platform. S is setting information to a patient regarding the risks and benefits of immunization. P is the problem or phenomenon in question. On Feb 20, 2007, this TI is timing, is perceived as positive, ambiguous or negative. So these are the three outcomes. So was the search comprehensive? They had used the keywords as, so the hint is appropriate platforms and appropriate social media search terms. So the keywords that they use are immunization, vaccination, employing a platform filter based on relevance. So anything close to the keywords will appear on the search list. I thought they could have broadened the search by employing words like vaccine. They only use vaccination. Or specific vaccines of interest, like they could have put influenza or HPV and broaden their search. Non-English videos were excluded, did not include other platforms. They had taken about 153 videos, but they did not display a flow diagram figure outlining selection process. How many did the search have? How many did they finally pick? How did they exclude? The reasons for exclusion. So this is the baseline characteristics. So if you can look at it, the outcomes which are rated as positive, 73 of them were rated positive, meaning that once he's looked at the videos, 73 of those videos had advocated vaccination. So that is 73. Ambiguous is whether they could not come to a consensus from looking at it whether it was a positive or negative, or there was a debate on it. So this viewer rating is basically like we rate on YouTube. So if you can look at it, most of those have done fairly well. Most of them were rated about 3.5 to 5.7. Of the viewers, this is the percentage that had actually rated. Was the study process reproducible? So the video screening and data abstraction were performed by two reviewers in parallel, which is independently, and the discrepancies were resolved by a third party arbitrator. The kappa score was 0.93, indicating almost perfect agreement. So sir was teaching us this last time. This is basically when two people are analyzing the same thing. Either they can both agree or either they can both not agree, or sometimes it can be like he says yes and no. So if it is one, it means that each time one person is saying yes, the other person is also saying yes. So 0.93 is close to 1, which is most of the time the two people have agreed that it is either positive or negative, or it is ambiguous. The authors did not report a pre-specified plan or protocol in the study design. So were the synthesis methods of the study appropriate? So they had chosen a descriptive analysis. They had provided baseline data on the videos which we had seen: video type, clip length, video count and viewer. And for the content categorization, they had given specific instructions as what is negative, positive and ambiguous. Negative is they had opposed immunization. They had emphasized the risk, advocated against immunization, emphasized distrust in literature. Positive is when they had emphasized the benefits, encouraged immunization, or ambiguous. There was a debate or present with ambiguous. So for this question and this study design, qualitative synthesis methods was appropriate to answer the question. What is the certainty? Essentially the limitations. So first thing is study limitations. It was an observational study. So they were prone to selection and outcome assessment bias. But because they had two independent reviewers doing it in parallel, we could have avoided that. The second thing is the claims regarding immunization are classified as substantiated. Like I said, all of these outcomes are actually against a gold standard. So if the study used a gold standard that determines accuracy of information on social media sites, was this gold standard appropriate? So for this they had used the 2006 Canadian immunization guideline, and they had, if the question to, so they had used, if the question to that, the answer to the question is yes, and it is also yes in the Canadian one, so then they are at sync with each other. We can look at it next one. Adequacy of data, so it was a cross-sectional design. They had looked at 153 videos, so was this enough or not is for us to decide. Maybe enough looking at the question. Inconsistency. Inconsistency is basically whether there is a difference across platforms or within the platform. So they did not specifically evaluate other social media platforms. Indirectness is applicability. So YouTube being the largest one video sharing app, they had picked YouTube. And they had also provided actionable outcomes at the end of the results. So they had suggested that there has to be improved surveillance and screening from the YouTube producers to display more credible video sources and information. Also, the need for clinicians to be aware of the significant anti-immunization representation on the internet video sharing sites. This is how we would act based on the reports. So we look at the results. So I just picked one, just this one alone. So if you can look at it, thimerosal immunization. So if it is substantiated, meaning if the answer to this question is the same as the answer to the question on the Canadian immunization guideline. So here, if you can see, all of them are actually negative, which means that the Canadian guidelines are saying you should take the vaccine, but these people are all against it. Yeah. So this is the end of the appraisal here. So now I have picked another small study, and I have given the guidelines at the end of it. So the hint is there, and I have also given some extra hints. So maybe you can take 10 minutes time and we will discuss this.
We'll send the same thing on WhatsApp.
On mail also. So at the end of it is paper where you can work on. The ones in the box is what the paper had given, and the ones on the left side is I have given extra hints. Most of the questions you can answer from the abstract itself. finishes, we'll start.
Last question is very small, but this one is very small to read. Do you understand?
So I think the last one is like, the font is too small, you can just look at that. Okay, we'll start. So the question is this. So a general surgeon has observed an increasing number of consultations from patients requesting cholecystectomy for asymptomatic cholelithiasis. Additionally, it has come to his attention that some of these patients have attempted a gallstone flush, a mixture of olive oil and lemon, prior to seeking medical advice. This trend raises concerns about the sources of health information that patients are accessing, particularly regarding non-evidence-based treatments. So for that, all of you have picked this. YouTube as a source of patient information on gallstone disease. Okay, so did the study explicitly address a sensible clinical question? So group A, B, C, D, E. Whoever answers will get 1 point. Yeah, so what was the background? Yeah, okay. So there are so they have said that there are very few indications for treatment of asymptomatic gallstones. Symptomatic gallstones should be treated with lab chole, and only medication that is likely to benefit is UDCA. So the research question, so you all felt here clear research question. So what information is being conveyed to the patient who watches YouTube videos regarding gallstone disease, and what is their response to the video? So they had picked only YouTube videos. So yes, no, maybe to that question. Did the study explicitly address a sensible clinical question? All of you, yes. Shannon, yes, no, maybe. Okay, yes. So did any of you come up with this? So this is like the PICOT statement. So perspective, setting, problem in question, timing, findings. It was actually the physician's perspective. No? He was the one who was looking at the videos and saying whether they were accurate or not. Okay, then physician is the perspective. Setting was YouTube platform. Problem in context was gallstone disease. Timing was in 2008 something. And findings were
very
useful values. Okay, from the perspective of a researcher on the YouTube platform, information to a patient regarding gallstone disease, on September 2013 is perceived as not useful, slightly useful, useful, very useful. This is the findings. So everybody got it right. Okay, was the search comprehensive? Evanglin, you want to say anything more? Anything you want to say? Okay, so the keywords that they had used were gallbladder disease, gallstone treatment, and gallstone and disease. They had employed a filter which is relevance. They could have also used, although this was meant for patients, they could have also used cholecystectomy, cholelithiasis, and cholecystitis. The ones not in English, videos with no audio, surgical videos, videos aimed at professionals, all of them were excluded. They did not include other platforms like Twitter, Facebook, etc. And for each keyword, they had 3 keywords. I made a mistake here. They had picked 100. So there are essentially they had picked 300 videos at the end of their search. And they did not display a flow diagram figure outlining the selection. So what do you say? Yes, no, maybe? No. Maybe. Okay. Maybe. Okay, I say maybe. I'm the speaker today. So was the study process reproducible? Okay. So the result is based on an established protocol. Authors present measures of agreement among reviewers. So they had a specific research question. There were 3 researchers and an additional researchers, all of them working independently in parallel. All researchers had finished their respective residencies at tertiary centers, which means that they were competent enough to decide whether the decision was right or wrong. The disagreements between the researchers were mentioned and they had actually come to a consensus at the end of it. The inter-observer variability was 0.94, 0.84 and 0.8, which is close to 1. And so the variability was not significant. There was no protocol per se. So overall, was the study process reproducible? Okay. So were the synthesis methods of the study appropriate? So basically, these could be narrative or quantitative methods. How did they analyze the data? What were the outcomes? That is the question. Yes, no. Okay, we'll get it. So they had picked a descriptive analysis and they had given us the baseline characteristics like video source, length, number of views, likes, dislikes, and days since upload. They had come up with a usefulness score to assess the information in each video, and this score was used to categorize videos as very useful, useful, slightly useful, not useful. So this is the usefulness score. So they had looked at cause, symptoms, diagnosis, treatment, recovery, and if it was not mentioned, they would get a 0. If it is briefly mentioned, they would get 1. In detail, then they will get 2. So 5 into 2 is 10. The maximum is 10. Based on that, if the not useful is 0 and the very useful is 8 to 10. At this point, we should also know that this was not a pre-validated score. So this is, so ideally they should have actually validated earlier and then used that score. This is only that score that they had come up with. So were the synthesis methods of the study appropriate? Yes. Last question. What is the certainty in the findings of the study? Study limitations? Did they use a gold standard? Okay. So it was an observational study design, so they were prone to selection outcome bias, but they have eliminated it by having 3 observers independently. There was no mention of a reference standard. He could have mentioned that according to the World Gastroenterology Guidelines this year, these patients need this, these patients do not need this. So he could have been more specific about his comparison. Adequacy of data, it was a cross-sectional design. They had identified 300 videos, 100 for each search word. There are 3 search words. Sample size, like I said, we cannot calculate. So this one, they had come to this 100 per word based on the assumption that nobody would go beyond first 5 pages of search results. So this is one way of coming up with the sample size. Each web page has 20 results, so 5 pages nobody's. So this is the assumption that he has made. So next thing, in the same thing, we had looked at study limitation and adequacy. Next thing is inconsistency. So he had not looked at other platforms. Indirectness are the data from the platforms relevant to the questions at hand. So they have taken YouTube, which is the largest one. They could have taken others. However, if you look at the final analysis, only 131 out of the 300 were included for the final analysis. They had excluded about 170. At the end of it, the actionable items that he has mentioned is creditable videos with accurate information need to be uploaded by medical professionals and medical institutions, and YouTube has to start filtering based on their search. So yes, no, maybe at the end of these 4 questions. In these 4 questions, he is at least done well in 2 out of the 4 criteria. So maybe.
The indirectness part, did they get was the question that was being asked, did the YouTube have the answers to the question?
They.
That is it. So there was no indirectness. They did find the answers they were looking for. If they didn't find the exact answers, then you say it's indirect. They got the exact answer, you could say there was less indirectness or there was more directness.
So maybe. So just to look at what the results of this study was. So he felt that 56%, 57% of the videos actually had misleading information, which is a big number. And it is good to note that the ones with the maximum likes, maximum views, maximum mean views are the ones with actually the useful ones. So it's a good thing to know that the useful ones were actually watched more than the other criteria. The next thing is the video demography. So who had uploaded it, either a physician or hospital, medical website or the commercial website. So most of them were actually from about 50% were actually from a commercial website. Again, a good thing is that the most watched ones are actually from a medical website. There were only 3 studies which were very useful, and they were all from a physician or a hospital. So this is how we had come to the conclusion of credible videos with accurate information need to be uploaded by medical professionals and medical institutions and not let it to the commercial websites. So that's about it. Thank you.